Hi everyone, great to see so many friendly and familiar faces and some new faces. So it's my pleasure to chat to you about the general pediatric papers that I found were particularly interesting over the last year or two. So the first one, I have to say I've got a weighted interest in, being 30 weeks pregnant at the moment, but very exciting is that this year Pfizer released a paper, and it was looking at a bivalent prefusion F vaccine, I believe it's called Brisvo, in pregnancy to prevent RSV illness in infants. And it's really interesting and topical because just in the last month, the FDA in America has approved it for use in 32 to 36-year-old pregnant women. So what exactly is this about? So this is produced by the Matisse study group, and they looked at 120 micrograms dosing without an adjuvant with a placebo. And the format that it comes in is a dry inhalation with a syringe that you're going to mix up to deliver. So they gave it to 3,578 women across 18 countries, including Australia, and they were 24 to 36 weeks gestation. There were some countries in Africa represented, India, Japan, a little bit in Europe, and then all across America, with the Americans being the bulk of the population. Around over 60% were Caucasian. There was a 20 to 30% Hispanic population. Asian population was around the 20% mark, don't quote me on that. And there was some representation of Pacific Islander populations and Native Americans, but those percentages were very small, sort of less than 1.5%, less than 0.5%. And it was a 1-to-1 vaccinated and placebo group. The interesting thing about this trial is that the governing board decided to terminate it early after interim data analysis at 180 days with 85% of the data. I think that that's a sign that the trial achieved what the investigators had hoped that it would achieve. However, personally, I would have been a lot more comfortable if they had decided to continue through with their protocol so we could find out a little bit more about it, which I'll discuss. So what exactly were they looking at? So their primary endpoints, they were looking at the efficacy of this vaccine and the safety of the vaccine. In terms of the efficacy, their main endpoints were severe RSV-associated lower respiratory tract infection and medically attended RSV-associated lower respiratory tract infection. And their time points were 90, 120, 150, and 180 days. In terms of safety, some of the measures they were looking at were reactogenicity, adverse events, which was sampled with a diary, as well as looking at symptoms at 3-7 days, a month later, and looking at the safety profile for both mothers and infants. So how did they define severe RSV-associated lower respiratory infection? I thought this was quite interesting. So the cutoff was that you had to have a central lab tested and confirmed PCR, confirming that the child had an RSV infection, and you had to have one of the following. You either had to have saturations less than 93%, a respiratory rate if you were under 2 months old of over 70, and if you were 2 to 12 months old of over 60, or you had to have high flow nasal prong intervention more than 4 hours in ICU, or being unresponsive, which I think we could all agree would be quite severe. I think that the interesting thing about the severity is that I would hazard to say that a lot of the children who get admitted with RSV get admitted because of poor feeding, work of breathing, and oxygen requirement, but I wouldn't necessarily personally have categorized them as severe in my mind. I would have said they're an RSV admission with bronchiolitis. So then when you look at the medically attended, this is looking at hospital presentations, medical presentations. This group was a little bit more generous, so you had to have saturations less than 95%, and in terms of the respiratory rate cutoffs, it was 60 if you were less than 2 months old, and it was over 50 if you were 2 to 12 months old with work of breathing. But again, you only had to have one of those symptoms. So if you had saturations of 94% with work of breathing, that would be considered a medically attended RSV-associated respiratory tract infection. So let's have a look at their graphs. So what you can see is that at 90 days, they found a vaccine efficacy in the babies of 82%, which to me sounds pretty good. Their cutoff for their confidence intervals, of which this was, I think, 97.5%, but all of the confidence intervals I discussed today are 95 or above, was 40 to 96. And for them, for the way that powered the trial, is that they wanted to have at least a lower limit of 20% as their confidence interval. So they've done quite well with this. At 180 days, the vaccine efficacy drops off to 69% with a CI of 44 to 84. And when you look at the data stretching out to 1 year, the vaccine efficacy drops a little bit further, but is around that 50% mark, but the confidence interval falls. So you can see over this time, the cumulative incidence of RSV with the placebo on top and the vaccine below. When we look at the medically attended, at 90 days, they didn't meet their primary endpoint, so the confidence interval dropped down to 15, but you can still see that there were around half the number of medical presentations of RSV compared to between the vaccinated mothers, infant population and the placebo. And at 180 days, that difference actually picked up, which is a little bit interesting. But again, the efficacy was around 50%. So it really does drop off at that 6-month time range. In terms of safety, common side effects, local site swelling was one of the most common, a little bit of erythema, headache, nausea. There were 5 serious events in the mothers, 4 in the trial group and 1 in the placebo. However, a lot of, which includes like SLE, there was a DVT, and it was generally felt that some of it was related to vaccine administration, but in terms of how it was actually administered. There were 17 infant toddler deaths. There were 5 in the vaccinated group and 12 in the placebo group. There was 1 RSV-associated infant death at around 4 months of age in the placebo group. The other interesting thing that people have raised sort of some questions around is that they did find that they had a slightly higher risk of premature infants being born in the vaccine-related group. And so I think that's why the FDA has approved it for 32 to 36 weeks, whereas in the study trial, they were 24 to 36 weeks. So they did have a small percentage of infants that were born before 34 weeks in the trial group. At the end, the bottom line is it is an exciting study and an interesting study, but one that I think we should have some caution and ongoing discussion about. You know, I am not an infectious diseases or immunology specialist, and for me, I was sort of like, well, you know, 40% CI, is that good? Is that not good? I'd really rather, you know, 99%. But life isn't perfect. When you look at other comparable vaccines like Prevnar and pneumococcal, you find that their efficacy rates are not too dissimilar. So I think that it's a really great space to watch. It'll be really interesting to see how quickly it gets implemented locally, and also looking at how this is going to change the face of general pediatrics and peds emergency in the future when we get vaccines like this rolling out. To go along with this is a different take on tackling RSV, which is to give a monoclonal antibody to the babies. So this was a paper looking at nirsevimab for prevention in late preterm and term infants. What this antibody comes from AstraZeneca and Sanofi, and it was produced by the MELODY study group. And it was also a phase 3 double-blind randomized control trial. So the way this monoclonal antibody works is it prevents the viral entry into the host cell. So who do they recruit? They had healthy over 35 weekers, and they had to be less than 1 year of age before the RSV season. They recruited just under 1,500 infants, and they did a 2-to-1 nirsevimab versus placebo. The infants less than 5 kilos would get a smaller dose of the antibody as opposed to the infants over 5 kilos. And that's interesting because if you look at the results, the children less than 3 months old, who would be in the smaller age group, did have slightly faster drop-off of their serum titers compared to the older children. So their primary endpoints were looking at efficacy, so medically attended RSV-associated lower respiratory tract infection at 150 days, and they also looked at hospitalization. So what did they find? So there was a significant difference in the numbers, so 1.2% versus 5%, and the efficacy for this was 74.5% with, again, a reasonable confidence interval. And as I mentioned, it was a little bit poorer if you looked at the subgroup analysis. So what does this actually mean for us? So that means that for every 1,000 children that receives this, you will prevent around 56 cases of RSV, as well as 15 hospitalizations. In terms of safety, it had a good safety profile, similar adverse events, and the adverse events, serious adverse events, were similar between the two groups. They did have a couple of deaths of the infants in that group, things like gastroenteritis, one which was undiagnosed death, but they thought was probably a chronic undiagnosed genetic condition based on the presentation, but it did not seem as if it was linked directly to the administration. So this is also really interesting. We use palivizumab in practice. We're seeing multiple different ways of targeting RSV infection in the community. And it'll be, I think that perhaps with the vaccine for the pregnant women, it might be more acceptable to families who would prefer to avoid giving their babies another jab. But potentially in the future, I could imagine we could have recombinant and combination vaccinations as well. So I've spent a lot of time talking about these two papers because I think they're really interesting and they're going to have a great impact on our day-to-day practice, but we can't forget the rest of general pediatrics. So this is a paper by Byrne et al. From Archives about the developmental behavioral outcomes in the coral cohort. So these are children who were born in Ireland within 3 months of the pandemic happening. And it was looking at, well, what are the developmental outcomes? So what we found in a previous coral study, which was looking at the 1-year outcomes, was that they had reduced social and communication milestones. So this was a follow-up paper looking at their 24-month outcomes. So they had 312 infants who were born in lockdown. And it's really interesting that the lockdown in Ireland was very severe and it was level 5 restriction, so staying at home, can't go out very much. And it was 87% of the time in the first 13 months of the lockdown pandemic for them. And they compared with a different baseline that they had from another study who were born in 2008 to 2011. So what did they find? So they found deficits between the two groups in communication and in gross motor with the ages and stages questionnaire scoring being 55 versus 60. There was also, as you can see, the children who were falling in the ages and stages more than 2 standard deviations were almost double in the COVID group compared to the previous control group as well in both communication and gross motor. They also looked at the child behaviour checklist and they found no significant difference but a slightly lower internal score for the COVID cohort. So what's the bottom line for this? I think that developmental pediatrics is a huge part of looking after children and a lot of us are sort of curious and have seen the knock-on effects from COVID. When I was working in a developmental clinic, we had a lot of issues with assessment administration, things like assessing autism because we had to wear the face mask, so we had a lot of staggered telehealth, and a lot of you may identify with the frustration of long wait lists, long times for assessments, and an overburdened system. I believe that the COVID pandemic has definitely had an impact on the development of our children, but it's not all negative. The fact that the childhood behaviour checklist was normal, the fact that the measures at 1 year had a greater difference compared to the 2-year measures suggests that kids are resilient and kids can catch up. And I think it's really about introducing more early intervention, being aware of the impact and really working together to mitigate this. As a related thought, I came across this interesting paper from Japan, and this was looking at screen time in the young population. So they looked at how much screen time you give children at 1 year and the subsequent development that they have at 2 and 4 years. And what they did find was that communication and problem solving were both lower in the ages and stages questionnaires at 2 and 4 years. What I thought was also interesting was the fact that it reflects a lot of the ongoing research that we know, as well as that even in Japan, families, I think all around the world sort of struggle with the day-to-day dilemmas of how much screen time to give children. And whilst more than around half of the population had less than 1 hour of screen time a day, almost 1 in 5 of their children had more than 4 hours screen time a day. So something to think about with your family, friends, and your patients as well. So moving on to growing up a little bit, here's a fun paper that I had from Sarah about the phenomenology of tics and tic-like behavior in TikTok. So what was this about? So they had a group of neurologists who reviewed the hashtag Tourette's TikTok videos from 37 users, and they used the top 100 of these papers. So why does it matter? Well, Tourette's syndrome is thought to affect 1% of the population, and talking to neurology colleagues and a number of papers, functional tic-like disorders are on the rise. So how did they look at this? So they had 2 neurologists screen each of the videos, and they looked at tic characteristic extractions. There's a very long table about all the different types of tics or characteristics of it, and they did a Likert scale scoring them from typical to untypical tic-like behaviors. They understand that there's a lot of limitations with this in terms of how much filming is there, what's been captured, and it's not as thorough as doing a face-to-face, and you don't know the background history. But what they did find was interesting. So the TikTok videos showed a lot of context-dependent tics. Over half of them were motor. There was a lot of coprolalia, so swearing, half of them, as well as phonic, so word type injuries. So for example, a teenager was putting makeup on her head and said Simba, and then she put it on someone else and she said Mufasa, and she was quite upset about it. Other things are they have this they have a trend where they try and hold an egg, and a lot of them throw it because of their motor tics. So there's throwing objects was featured in 22% of the videos, self-injurious behavior in about a quarter, and then obscene gestures in 1 in 5. So what did they find? They found that the mean scoring was around 4 and 5. So a lot of the TikTok videos were not typical or characteristic of what we would define a tic disorder as. In terms of how does that apply to our patients, we need to look at minimizing attention to tic-like behaviors. There was a recommendation that they avoid searching for or looking at these videos for at least 4 weeks. And then it's really about functional interventions, counseling, and discussion around things. My last paper is on the use of entrustable professional activities in the pediatric postgraduate medical education, a systematic review. Why did I pick this? So this year I'm the academic fellow at Westmead Kids, so I've been learning a lot more about, I guess, formal academia, as well as how do we produce good medical students? How do we produce healthcare workers that are going to do what we intend them to do? And the reason why I'm including this in the bubble wrap is that it's really important to understand what's going on, because it is going to be impacting trainees currently and trainees in the future. I'm on the Curriculum Advisory Board for the RACP, and they're currently rolling out a new program for advanced training, and that includes pediatrics in Wave 2. Implementation's not going to be for a few years, but all this kind of lingo is going to be common in the workplace here. So there's been a move towards competency-based medical education where we look at entrustable professional activities, and to look at and assess entrustable professional activities, we have something called programmatic assessment and workplace-based assessments. That all sounds very wordy. What does that actually mean? Well, we want to marry up the skills, the knowledge, and the attitudes that we hope healthcare professionals have. So what did the systematic review do? They screened 2,000 papers and they included 28. So there's a lot of research going on in academia about this. What I thought was interesting is in terms of development of these programs, they had stakeholder feedback for almost all of them, but only half of the programs had stakeholder feedback with learners. And only one of the programs of 11 took into account family and patient perspectives. And I personally think that we can and we should be doing better. I know it's difficult to get accurate representation, but if you are going to be putting forth a program without any representation from the people that you're asking to deliver that program, I think we have an issue. In terms of implementation, they found 3 studies that looked at governance, timeline, standardization, and multipliers. Regarding acceptance, they did find that this new wave of curriculum is acceptable. They acknowledge that there's a lot of commitment required to implement it, and that entrustment ratings, which is about the independence of learners, improved over time, as you would hope and expect. So what is the bottom line? It all might sound like a lot of jargon, but new curriculum is coming in Australia, and from looking at the research, it's rolled out over the last few years and will continue to roll out across the world. It's really important, if you are in academia, if you are in teaching, that you ensure that there's stakeholder representation, and it's essential for any new program, whatever it is, that we upskill faculty and learners. So hopefully you learned something new or two about general pediatrics and all the really exciting and interesting research that's come out recently. Thanks.